Right. So right at the beginning, I'm telling you now there will be a little repetition. That is just to reinforce certain things and also for to understand the process better, right? So something that we have discussed in the previous lecture. Also, I'm using a couple of slides. There are only about 10 or 11, I think. Here. Anyway, let's start.
Recording in progress.
In the previous lecture, we discussed obesity in detail and identified that obesity is a key risk factor for the development of chronic non-communicable diseases. And in this lecture, I would like to show you how obesity is linked to these NCDs, namely diabetes mellitus, hypertension, dyslipidemia, and cardiovascular disease. We can discuss the biochemical basis and mechanisms of these connections in this lecture. And then there will be a couple of more lectures to discuss individual conditions, namely diabetes mellitus and dyslipidemia leading to atherosclerosis and cardiovascular disease. Okay, first, let us see why it is such an important topic to discuss. Now we know that overweight and obesity is a complex, multifactorial, and largely preventable disease. This is seen in over a third of the world's population today, more than one third actually. And obesity has been a health problem all over the world. And its prevalence is increasing in both in developed countries as well as in developing countries. And according to WHO data, almost 40% of the global population above the age of 18 years are overweight and 13% are obese. So if the current trends continue, you can see where we will end up. So therefore, we need to appreciate the magnitude of the problem. So here is a condition which not only needs to be managed, but more importantly, it has to be prevented as much as possible. So this rapid increase in prevalence did not happen overnight. We need to understand why this is happening and how we can prevent further escalation of the problem. So I'm going to touch upon something that we have discussed before because it is very relevant to this aspect of our discussion today, nutrition transition. So we saw that it is a shift in our dietary consumption and energy expenditure, which is happening with the current economic and epidemiological and demographic changes. That's a definition, but practically we know that our routine diet has actually transformed from our traditional high cereal and fiber-based ones to more Western pattern of diet. And this transition is also associated with the physical activity levels and sedentary behavior. Again, our activity levels have really deteriorated from very high levels to very low levels, plus our current sedentary behavior patterns. Right. Now we can see what is happening around us. The changes of the transitional process like aging, rapid unplanned urbanization, and globalization of unhealthy diet, all these things we experience, right? And all this lead to poor dietary practices, physical inactivity, and sedentary behavior. Now, all these are modifiable risk factors. So we can either control them or prevent them. The risk of cardiovascular disease can be decreased by addressing these individual risk factors. Okay, so basically lifestyle modification can reduce these problems. So they, along with the non-modifiable risk factors like age and heredity or the genetic makeup, predispose to intermediate risk factors. Raised blood glucose, raised blood sugar, blood pressure, abnormal lipids or dyslipidemia, and overweight and obesity. So they too can be controlled with lifestyle modification. And if appropriate, sometimes you may have to use pharmacological treatment. Now, they in turn can lead to the chronic non-communicable diseases that we discussed in the previous lecture. Also, diabetes, mellitus, dyslipidemia, hypertension, and cardiovascular disease, and also certain cancers. I took this figure from a position statement of the World Obesity Federation, and this shows the relation of obesity and the diseases with which it is associated. Right? So you can see diabetes, mellitus, cardiovascular disease, hypertension, and of course we know that it is associated with certain stigma. It can lead to sleep apnea syndromes, osteoarthritis, gallstones, and certain cancers. And these boxes show the pathophysiological factors that are principally involved in the development of these diseases. So many of these pathophysiological factors do interact with one another and be involved in more complex pathways. But for the clarity, let's consider them like this. Otherwise, there are so many interconnections and there are interrelationships. But for clarity, we'll just take this diagram. So you can see the diseases and how they are linked to obesity. So there are so many studies that demonstrate a relationship between obesity and hypertension, diabetes mellitus, dyslipidemias, and there are studies that show an increase in the incidence of cardiovascular disease with obesity. However, these connections are not so simple, they are complex. So to make it a little simple to understand and be more focused and relevant to our discussion today, let's look at this chart briefly. So now you have obesity there, abnormal body composition, excess fat, etc. And we know that the physical inactivity can lead to obesity, and also it can lead to diabetes mellitus. And then this obesity is linked to dyslipidemias, hypertension, and hypertension in turn can cause coronary heart disease, and diabetes also can cause coronary heart disease, and obesity leads to hypercoagulable states, which again is a risk factor for cardiovascular disease. So there are many connections and relationships between these conditions. Let's see the basis. So it has become very clear that the cardiovascular disease risk factors that we discussed today, obesity, hypertension, dyslipidemia, and diabetes, tend to cluster or occur together. Right? So they tend to occur together, and also that the lifestyle modifications of dietary change and increased physical activity can actually significantly reduce these risk factors simultaneously. And in doing that, it can reduce the risk of cardiovascular disease. So the literature shows that they are interconnected in the causation as well as in the management. So some authorities think that this clustering of these risk factors and their shared uh, responsiveness to lifestyle modification, and they think that they are not independent of one another and that they share underlying causes, mechanisms, and features. So there's a bit of a controversy regarding this, and I will discuss the basis for that a little later. Now, if all these conditions exist or diagnosed in the same person, they call this condition metabolic syndrome. So the metabolic syndrome refers to the co-occurrence of several identified cardiovascular risk factors, including obesity, insulin resistance, atherogenic dyslipidemia, and hypertension. And it can be explained how these conditions are interrelated and share underlying mediators and certain mechanisms. Now, this slide shows some of the diagnostic criteria used by different authorities for metabolic syndrome. Right? So these are four of the most commonly used definitions of metabolic syndrome. WHO, or the World Health Organization, developed its definition way back in 1998. And the WHO was, I think, the first to consider the key components of insulin resistance, obesity, dyslipidemia, and hypertension together, right? So we can see here that all these definitions include obesity, right? So all these have obesity as a criterion, right? And in the International Diabetic Federation definition, obesity is an absolute criterion that has to be there in that classification. So all these include insulin resistance or diabetes, hypertension, dyslipidemia. All these are common for all these definitions. So for today's lecture, I would like to consider the relationship between the components of metabolic syndrome, because that will help us to understand the biochemical basis and pathophysiology that links them with each other and with the increased risk of cardiovascular disease better. To understand the risk factors associated with this condition and to see how we can diagnose this, let's look at this very, very simplified figure. So now if you take insulin resistance or hyperglycemia, you can do fasting blood sugar and HbA1c. Both will be elevated. And then you can check the blood pressure, and the blood pressure is elevated. Atherogenic dyslipidemia, you don't individually look for these components. You basically do a lipid profile, which has total cholesterol, LDL levels also will be high in this condition, and you have triglycerides, which is high, and the HDL levels. HDL levels will be low. And metabolic syndrome is a pro-inflammatory state or hypercoagulable state, and HSCRP is a marker of inflammation, right? So HSCRP usually goes up. Hypercoagulable state, increased amounts of fibrinogen will reflect that it's a prothrombotic or hypercoagulable state. Abdominal obesity, you can confirm by measuring the waist circumference. Okay, let's take a 2-minute break and come back. Okay, let's resume. Now let's try to recap a little biochemistry here, right? In your biochemistry lectures, you have learned that insulin is produced by the pancreas in response to hypoglycemia, right? You know all this. To reduce glucose that is in blood, skeletal muscle, liver, and adipose tissue remove or take up glucose from the circulation, right? So that is clear. And in the skeletal muscle and adipose tissue, insulin stimulates glucose uptake by uh, GLUT4 glucose transporters. And in the skeletal muscle and liver, insulin stimulates the synthesis of glycogen from glucose. So that's a storage form because there's a lot of glucose in the circulation, and also inhibits glycogen breakdown, right? Because if glycogen breaks down, that will come to the blood and further raise the blood sugar level. And in the liver, insulin also decreases hepatic gluconeogenesis, preventing the release of more glucose into the bloodstream. And in fat cells in adipose tissue, insulin inhibits fat breakdown or lipolysis and stimulates glucose uptake. So the net effect of all this is to increase glucose uptake by peripheral tissues and to reduce circulating glucose levels, right? And at the same time, convert glucose into the storage molecules, glycogen, fat, and store them, right? So this is what usually happens. And from your biochemistry knowledge, you know that. Now in insulin resistance, all these things happen if there is insulin. Now in insulin resistance, adipose tissue, muscle, and liver cells do not respond properly or appropriately to insulin. So the circulating insulin, the circulating glucose levels remain high. Okay, so now let us look at the molecular basis, right? So now adipose tissue affects metabolism by secreting a lot of hormones. We saw that. And there are other substances like leptin, adiponectin, then pro-inflammatory substances like human octosis factor alpha, then you have free fatty acids. All these are secreted by the adipocytes. So in obese individuals, the secretion of these substances is increased. So increased release of non-esterified fatty acids or free fatty acids is observed both in type 2 diabetes and in obesity. And it is associated with insulin resistance in both these conditions. So free fatty acids are released in large numbers from the expanded adipose tissue. And in the liver, these free fatty acids produce an increased production of glucose, triglycerides, and secrete VLDL. So you can see that the associated lipid abnormalities here include increased LDL and reduced HDL, and there's increased triglyceride formation in the liver, right? And then there are many mechanisms for insulin resistance, and you will learn more about them in the lecture on diabetes mellitus. But here I'm trying to show one mechanism that may link obesity or expanded adipose tissue mass leading to insulin resistance. So free fatty acids can reduce insulin sensitivity in you take muscle. So in muscle, what happens is it can inhibit the insulin mediated glucose uptake. Now you have glucose coming in, and if there's insulin, this glucose can get into the muscle. But free fatty acids seem to interfere with this, right? So that causes insulin, the resistance to the action of insulin. Then insulin sensitivity is also determined by the body fat distribution. So individuals whose fat distribution is more peripheral, have more insulin sensitivity, right? Than the individuals whose fat distribution is central, or we call abdominal fat, abdominal obesity. So in people who are having more central fat or abdominal fat, there is more insulin resistance, because abdominal fat is more lipolytic than subcutaneous fat, and it does not respond easily to the action of insulin, which makes this intra-abdominal fat more important in uh, causing insulin resistance and diabetes. So remember, intra-abdominal fat compared to peripheral fat is less sensitive to insulin and causes insulin resistance, which can lead to diabetes mellitus in future, and also to other NCDs. Coming back to the increased glucose level, to some extent, free fatty acids also play a role in increasing this insulin secretion from the pancreas. Glucose we know, but free fatty acids also have a role in that too. Right? So we know that there is hyperinsulinemia, and this hyperinsulinemia in turn can result in increased sodium reabsorption and increased sympathetic activity, and they together can contribute to hypertension. So there's increased levels of insulin because there's insulin resistance, and that along with this sympathetic, so this leads to sodium retention, and along with sympathetic nervous system activity and possible role of free fatty acids, hypertension can develop in patients with high amounts of adipose tissue or people who are obese. Right? So that was about the biochemical and pathophysiological basis of metabolic syndrome, or when all these conditions are seen in the same person. Right? However, I told you there has been controversy regarding metabolic syndrome. That is not to say that such connections do not exist, but certain authorities have problems with the definitions and various aspects of this disease. American Diabetic Association is one authority that has certain concerns, and another one is the EASD. EASD is European Association for the Study of Diabetes Mellitus. Just check that. It's EASD. So they question the validity of this metabolic syndrome. So some of their concerns are that they say that the criteria for the diagnosis are ambiguous. And they question why diabetes mellitus is included in the definition. Right? And also they say that there's no clear basis for including or excluding other cardiovascular risk factors. Why only these? And why have you included these? That is their question. And also, I think for me, the most important argument is the risk associated with this metabolic syndrome is not greater than the sum of its parts when you take separately. Now, if you take separately the four components, when you put them together, when you see them in the same person, if there is an increased risk, then they say there is a point in naming such a disease. But if the individual risk, when you put them together, when you add them together, if that is same as the combined risk, then there's no point in talking about a condition like this. That is their argument anyway. And so that is why they say that there's no medical value of diagnosing this syndrome as a cluster. But anyway, we need to remember that it is that obesity can be linked to diabetes, hypertension, dyslipidemia, and cardiovascular disease independently anyway, right? I just wanted to discuss metabolic syndrome for this lecture because that gives us the opportunity to explain the links. And also, metabolic syndrome is a recognized entity, right? But you have to really remember that a person who's obese can have only hypertension or only diabetes or initially just obesity, right? So there can be this relationship in one person, or you can have individual NCDs in certain people, right? Right. Now, if you take hypertension, right? Now, activation of the sympathetic nervous system, we saw, play an important role in the pathogenesis of this obesity-related hypertension, right? And because there is some amount of sodium retention as a result of increase in renal tubular reabsorption of sodium. So the extracellular fluid volume is increased and the kidney fluid apparatus is reset to a higher level, to a hypertensive level, as you may have learned in physiology. So this is basically due to fluid retention and sympathetic activity. But independently, in obesity, we see that plasma renin activity, angiotensinogen levels, then angiotensin 2 levels, and aldosterone levels, all those chemical substances go up significantly in obesity. Right? So, because of that, we can say that if a person is obese, there is a high chance that the person will end up having high blood pressure. Then also insulin resistance and inflammation, then you have leptin and other neuropeptides are also possible links between obesity and the development of hypertension, but they are not very clear. So you can read a bit about the mechanisms of obesity-induced hypertension. Just a slide about high blood pressure. It has been shown that there's a relationship between high blood pressure and cardiovascular disease, and this relationship is continuous and positive. That means when the blood pressure goes up, the cardiovascular risk also goes up along with that. Right? And if the blood pressure is high, the arteries get hardened. They lose the elasticity, which is not good. And then high blood pressure can predispose to stroke, myocardial infarction, congestive cardiac failure, heart failure or cardiac failure, then peripheral artery disease. And then remember, this is one of the main causes, apart from diabetes, for chronic renal failure. And high blood pressure can cause retinopathy and is a cause for blindness. Now, I mentioned that obesity is a hypercoagulable state, right? So, in obesity, certain hormones act as prothrombotic adipokines. I mean, not in obesity, in people, right? In normal people. Say leptin, plasminogen activator, inhibitor 1, resistin, all these are prothrombotic. That means they are for clotting. They potentiate clotting. And then you have antithrombotic adipokines like adiponectin, right? So they try to sort of prevent thrombosis. But in obesity, what happens is there's a disruption of this balance. So there's an imbalance between prothrombotic adipokines and antithrombotic adipokines, which leads to a hypocoagulable state. Okay. Right. So in the previous lecture, we discussed the biochemical basis of obesity. And then in this lecture, we tried to deal with the mechanisms of how obesity is linked to other chronic non-communicable diseases. We just discussed briefly about insulin resistance and how it leads to dyslipidemia and how it leads to a procoagulable state or hypocoagulable state. And in your next lecture on biochemistry of diabetes, you will learn more about insulin resistance and about diabetes mellitus. And then there's another lecture on lipoprotein and cholesterol metabolism, where you will learn more about dyslipidemia leading to atheroma formation, atherosclerosis, and coronary artery disease or cardiovascular disease. So that covers obesity and obesity-related chronic non-communicable diseases. Thank you.
Recording stopped.
Okay, so that's about it. So other lectures, one will be done by Professor Lani Landrol on diabetes, and Dr. Taranga Toradenia will do on lipoprotein abnormalities. Right. So far, how are things in the module? Are there any problems, any issues? All right. If there are any issues, just please let me know, or you can call Dr. Madhuka Dilandrol as. So we are there to help you if there's any problem. Okay. I'm a little concerned about this very low attendance, but of course I appreciate that it is difficult times for you and for all of us. So it's fine. So we'll try to upload the lectures as well as the lecture slides. Okay.
Thank you, sir.
All right. Okay, then all the best.